Assalamu alaikum everyone. I'm Salsabil Haque, a fifth-year medical student currently, and today I'm going to be giving, inshallah, a crash course on the pharmacology aspect of GIT. Now, it is going to be about 6 lectures, inshallah. These are the lectures. And before I begin, I want to say if you have any questions at any point regarding the questions I put on the slides or any of my slides, feel free to contact me. My contact information is right here. So let's go ahead and get started. So pharmacology is one of those things that's just purely memorization and purely just how much you can recall in the exam. And so it might seem a bit daunting for me as well. Pharmacology is my least liked discipline of medicine. However, if we really sit down and think about it, it really comes down to these parts. And it sounds very obvious. We should all know this. But if you really feel overwhelmed, I would suggest sitting down and going through all the drugs and just making sure that you know these aspects for each drugs. When you really think about it, it's really not that much when you think about these aspects only. So I only need to know the mechanisms, the indications, the contraindications, side effects, and anything that makes it different or anything that's a keyword that I can instantly recognize in the exam. All right. So for every, like when you're revising for your exam, make sure you have a checklist of in your mind that, okay, so I have antiviral drugs for hepatitis. For each of them, do I know the names? Do I know the mechanism of actions, indications, contraindications, and side effects? When you get that down, inshallah, there's no question on earth for pharma that can stop you because essentially these are the only things that they can ask. Okay? All right, so let's start with the first lecture, anti-emetics and prokinetics. Okay, just a bit about how nausea and vomiting occurs. So there are quite a few reasons why nausea and vomiting can occur. So in the slides, we have quite a few reasons. So it can be because of GI disturbance, as we know, if we get food poisoning or any infections in the GI, it can lead to nausea and vomiting. And the pathway that it involves is the one right here. So here, if there is something in the GI tract, through the serotonin neurotransmitter and through the vagus nerve, it goes to the solitary tract nucleus where it triggers the brainstem vomiting center. Okay. Otherwise, if you have something that activates your gag reflex, for example, you ate something bad, or something that goes to your upper pharynx and activates your glossopharyngeal nerve, that also activates your brainstem vomiting center. All right. So this is the peripheral one, kind of. So your gag reflex and any GI disturbance. Other causes of vomiting can also be central, right? So if there's a patient who takes chemotherapy, for example, those chemotherapy can go to this area called area postrema, which is also known as the chemoreceptor trigger zone. So it is not guarded by blood-brain barrier, and this is why it can detect all the chemicals and then transmit through these neurotransmitters to the brainstem vomiting center. Okay. Another mechanism is when you are in a ship, let's say, or a boat, and the motion is making your cerebellum activate the brainstem vomiting center again. So the vestibular system, which maintains our balance, when this balance is imbalanced, let's say, the cerebellum and the vestibular nuclei carry neurotransmitters to activate the brainstem vomiting center. So we know of so many different reflexes and so many different mechanisms. So the gag reflex, GI disturbance, chemotherapy-induced, motion sickness, right? Motion sickness as well. The last one is something that goes to the higher center, so even the cerebral cortex, right? It goes there and it activates fear or memory. So patients who are on long-term chemotherapy, sometimes when they start a new cycle of chemotherapy, before even starting, when they go to the hospital and they smell the gloves or they smell the hand sanitizer, they might get something called anticipatory vomiting. Okay, so there are so many different mechanisms, but why is this important to know in the aspect of pharmacology? It is important to know because we need to know the neurotransmitters. As you can see, different pathways employ different neurotransmitters, and there are a lot of overlap between them, but there are also some differences between them. As you can see, D2 receptors, serotonin receptor, muscarinic, neurokinin 1, or substance B receptors are all involved in the blood-borne pathway and also the peripheral GI tract pathway. Histaminic and muscarinic receptors, as you can see, are involved in the motion sickness pathway, and ultimately the neurokinin 1 receptor is involved in the brainstem vomiting center. So all of these receptors, since they're involved in the vomiting center, our job or the pharmacology, the job of the drug that we would give in order to stop vomiting would target or antagonize these receptors, right? Makes sense. So when we memorize it like this, it becomes way easier. So what receptors do we have to antagonize? Serotonin receptors, D2 receptors, muscarinic receptors, and histaminic receptors. Okay, so now we can begin. Our main job is to target the receptors, antagonize them so that we can stop the vomiting and nausea. Okay, the first transmitter that we want to antagonize is dopamine antagonists, dopamine, right? So what are these drugs? Metoclopramide and domperidone. These are very famously used drugs, and they antagonize D2 receptors in the chemoreceptor trigger zone and the solitary tract nucleus. So both central and the nucleus, which is also central, essentially. So they antagonize dopamine receptors there. However, these D2 receptors are used in preventing unusual movements, right? So remember when you took in neuro, the basal ganglia, it helps us prevent unusual movements. However, when these receptors are antagonized here, we're going to have unusual movements. That's what the main concept is. So when patients take metoclopramide, sometimes they develop something called extrapyramidal symptoms. Why do they develop these? Because D2 receptors usually are inhibitory and they stop patients from they stop people from having like twitches or extra motor symptoms that are unnecessary. However, when you antagonize these receptors, you can have extrapyramidal symptoms. What are those? As you can see here, I hope you can see this part of the screen. So they can be acute dystonia, so muscle contractions in the neck. It can be Parkinsonism symptoms such as shuffling gait or resting tremor, rigidity, a pin rolling tremor, etc. And akathisia, such as it makes you want to do repeated movements, something like this. Okay? All right. So these are extrapyramidal side effects, and they can be caused by metoclopramide. Now, as you can see, there are two drugs here, metoclopramide and domperidone. Metoclopramide causes extrapyramidal symptoms, domperidone doesn't. Why? Because metoclopramide can enter the blood-brain barrier, and it can affect the D2 receptors in the brain. However, domperidone cannot. And how do I remember this? It's a very stupid mnemonic. By the way, through this session, I will have very, very stupid mnemonics. Please don't judge me. And yeah, feel free to use them. Okay, so metoclopramide, domperidone, it's kind of like, it's dumpy, it's dumb, basically. So it doesn't go to the brain, it doesn't cross the brain. However, metoclopramide, it is smarter, so it crosses the brain. Another side effect, as you may remember from EndoRepro, is that dopamine receptors inhibit prolactin. So when you have antagonization of dopamine receptors, you have activation of prolactin. And activation of prolactin unnecessarily can cause gynecomastia. And this can unfortunately happen in both patients taking metoclopramide and domperidone. This is because pituitary is not really in the brain. It doesn't really have a blood-brain barrier. So obviously both of these drugs can affect it. Now, what are the uses of dopamine antagonists? You have migraine, chemotherapy, levodopa, a use associated with nausea and vomiting. So sometimes people take levodopa for what disease can you think? Yeah. So it's going to be Parkinsonian disease, right? So sometimes they might have nausea and vomiting related to the excess of dopamine. So when you give them dopamine antagonists, that can cause decrease in the nausea and vomiting symptoms. Diabetic patients develop gastroparesis. What is gastroparesis? It's kind of slowing of the bowel due to neuropathy or due to underlying pathology of the diabetes. Or it could be, underlying pathology of diabetes. And dopamine antagonists can also be used to improve kinesis. It has two functions. It can stop nausea and vomiting, and it can improve GI motility. So because of prokinetic functions, it is used in gastroparesis and diabetes. Okay, other dopamine antagonists are typical antipsychotics such as chlorperazine and chlorperazine. These are used for more severe nausea and vomiting. Now, how can you remember this? Remember, metoclopramide and domperidone are the first line in case of dopamine antagonist, and then more severely, obviously, we're going to give antipsychotics. It makes sense because anyone with nausea and vomiting, we're not going to start them off with antipsychotics. All right. Now, another receptor that we're going to target is the serotonin antagonist. Serotonin antagonist, it ends in cetron, so ondansetron and pelnosetron. How do I remember the serotonin antagonist? You're going to remember the association between serotonin, which is a very happy hormone. That when we think of serotonin, we think of stuff that makes us happy, right? So serotonin makes you want to dance. That's how I remembered. So on dance citron, I want to dance with serotonin when I have serotonin, basically. Ignore the antagonist part. But remember that it's antagonist, which is the slight caveat in our mnemonic. But yeah, ondansetron and palonosetron. Palonosetron is just one of those things that's mentioned in the slide, and we have to remember it. It is a superior palonosetron. However, it is parenteral. P for palonosetron, P for parenteral. So obviously it blocks serotonin receptors in the chemoreceptor trigger zone and the GIT, which is also influenced by serotonin receptors. Side effects, it has very mild side effects such as headache, and uses are usually chemotherapy-induced nausea and vomiting. Okay, so ondansetron, the first line of treatment in chemotherapy induced nausea and vomiting is ondansetron. And it is also used in post-operative nausea and vomiting. Okay, that's pretty much it. There's not much more to it. Now, another um, receptor that is targeted is antihistamines. Now, we will take antihistamines in two places here in throughout our session in GIT. One is here because for nausea and vomiting, and the other one is in peptic ulcer disease drugs. The it might be confusing. However, the difference between the drugs here and the drugs in the peptic ulcer drugs is this is H1 receptor antagonist, and those are H2 receptor antagonists. So that's very, very important. H1 receptor antagonists, such as dimenhydrinate, diphenhydramine, meclizine, or promethazine. They are antihistaminic agents which block H1 receptors, and they also have some anticholinergic effects. There are first generation antihistamines can only enter the blood-brain barrier. So when we think about antihistamines, we always think about allergies, right? So it makes sense that no, it doesn't make sense, but like I don't know if you guys heard oh okay when I take allergy medications I get very sleepy. So so that's how you can relate this to this. So the side effects would be sedative side effects and also anticholinergic side effects. Mainly the sedative side effects with first generation antihistamines. Because it can enter through the blood-brain barrier, it causes sedative side effects. However, then they developed second generation side of antihistamine, which does not really have these side effects. The sedative side effects, I mean. Um, it also affects anticholinergic uh, receptors, mild anticholinergic effects, so it can cause anticholinergic side effects as well. So how do we remember anticholinergic side effects? It's a mnemonic that I've heard a lot of places. Hot as a hair, dry as a bone, red as a beet, blind as a bat, mad as a hatter. I know it works for some people. I don't really use this mnemonic personally. I just think that anticholinergic means everything that is not parasympathetic. Parasympathetic are all the functions that we do when we rest and digest, right? So lacrimation, sweating, or what do you call it? Urinate or defecate. All of the GI functions, urinary functions, salivation, etc., are all parasympathetic functions. So when we inhibit the parasympathetic functions, we don't want to rest and digest anymore. So we will have diminished bowel sounds, constipation, right? Even ileus at some point. Ileus is the absence of any bowel movement. So these are anticholinergic side effects. We can have urinary retention, warm and dry skin, dry mouth because of lack of salivation, dry eyes because of lack of lacrimation, and also, uh, what do you call it? Mydriasis. All right, mydriasis because if we don't have parasympathetic function, we will have sympathetic function. And what is the pupillary effect of sympathetic function? It is dilation of the pupils. So we'll have mydriasis, dry eyes, dry mouth, tachycardia, diminished bowel sounds, so constipation, and urinary retention. So what are the uses of antihistamines? They're used for morning sickness, and famously this combination is used, which is doxylamine pyridoxine or meclizine and pyridoxine. So vitamin B6 along with antihistaminic agent. Motion sickness, so promethazine is used for motion sickness, and for hyperemesis gravidarum, promethazine is also used. Motion sickness, promethazine is used, but is not the first line of treatment. Scopolamine is the first line of treatment, which we'll be coming to. All right, so next we have the antimuscarinic receptors. So we covered dopamine antagonists, which is metoclopramide and domperidone. We covered the antihistaminic agents such as diphenhydramine, meclizine, promethazine, etc. Now we're coming to antimuscarinic agents. So antimuscarinic agents include scopolamine, and it's a transdermal patch that is used in patients when they anticipate that they're going to have motion sickness or when they have motion sickness. So it causes muscarinic blockade, in the vestibular system because that's the origin of motion sickness, right? Sedative effects are again anticholinergic effects. I'm sorry if this is, yeah, I don't think it should be sedative effects here. It's going to be anticholinergic effects. I'm sorry about that. I'll actually change that now. Yeah, just so when you guys get the slides, you guys can refer to it. Okay. So anticholinergic side effects, the same ones we mentioned, dry as a bone, so no lacrimation, no salivation, mydriasis, constipation, and urinary retention. Okay. Uses, it is also used in motion sickness, most commonly used in motion sickness, scopolamine. Contraindications, however, are acute angle closure glaucoma. So now, as we mentioned in the pupils, since we don't have parasympathetic activity, we have an overwhelming sympathetic activity. What does this cause? This causes mydriasis. Now, people who have acute closure glaucoma or a history of acute closure glaucoma, they already have an increased intraocular pressure. Now, when we dilate the pupils, we kind of block the trabecular network in the eye, and this further increases the intraocular pressure. So with patients with acute closure angle glaucoma, we will avoid antimuscarinic or scopolamine because of worsening of the glaucoma. All right? Okay. We also have some adjuvant therapies that are used, such as cannabinoids. They act in the cannabinoid receptor, and they're basically what do you call it? Like marijuana, but like medical marijuana, basically. So cannabinoid receptors, and their side effects are euphoria and other like weight gain, conjunctival injection, and yeah, just hyperphagia, basically, increase in appetite. So those are used in sometimes in anticipatory nausea and vomiting to calm the patient down, relieve anxiety. Speaking of anxiety, benzodiazepines are also used as adjuvants, and they're the drugs that are ending in PAM. So lorazepam, diazepam, those drugs. And they're also used in anticipatory nausea and vomiting just to calm the patient down. Because remember, in anticipatory nausea and vomiting, higher centers are involved, such as cerebral cortex, and those can cause fear or memory. Those can elicit fear based on the memory. And yeah, so they're used. And so we can use benzos and cannabinoids. And also neurokinin 1 receptor antagonists such as aprepitant. This prevents delayed nausea and vomiting, and it is often used with other drugs in order to prevent the production of substance P. All right. Okay, so this is a rapid review. When you think about chemotherapy, what is the best drug to use, do you think? It is going to be ondansetron, right? Morning sickness. What is the best drug to use? It is going to be, I believe, pyridoxine, the one, meclizine, pyridoxine, or the other one, I'm not remembering the name, but the ones with pyridoxine. In severe cases, we can also use promethazine, severe cases being hyperemesis gravidarum. So in hyperemesis gravidarum, what are you going to use? We're going to use promethazine, okay, which is an antihistaminic agent. For motion sickness, what are we going to use? We're going to use scopolamine, which is an antimuscarinic. For gastroparesis, we're going to use dopamine 2 antagonists, which are metoclopramide and domperidone. And there is also another drug that is mentioned in the slides, which is cisapride, which is Serotonin, we know 5-HT3 is serotonin. This is 5-HT4 receptor antagonist, and it's called cisapride. Okay, so it has pride because it's more than three, if that makes sense. So serotonin is 5-HT3. Cisapride is going to be 5-HT4. So it has more pride, if that makes sense. Sorry, it's just dumb. Whatever comes to mind, whatever to remember, right? Okay, so now we'll move on to questions. I tried to include as many questions as possible because the main way to study pharmacology is to just memorize as much as possible and then just do as many questions as possible. Okay, because there's only so much you can do to explain if we can't remember it. At the end of the day, pharmacology is just recall, unfortunately. It is good to understand everything. It is good to take your time to dissect and form mnemonics and all of that. But it really comes down to how much you can remember in the exam. Okay, 30-year-old woman receiving cisplatin develops severe nausea and vomiting 6 hours after chemotherapy. Which drug best prevents this? We said the best drug of choice for chemotherapy-induced nausea and vomiting is ondansetron. And what class of drug is this? It is a serotonin receptor antagonist. What side effects do you get? Mainly headaches. Yeah, that's pretty much it. Okay. All right. 24-year-old man develops involuntary neck muscle contractions 1 hour after taking an antiemetic. Which mechanism best explains this adverse effect? Is going to be dopamine D2 blockade. Because what are the drugs we're talking about? Metoclopramide? Yeah, metoclopramide, right? Not domperidone because it doesn't cross the blood-brain barrier. All right. Then, yeah, so that brings me to the end of the first lecture. We're doing well with time, alhamdulillah. All right, second lecture is the use of drugs in peptic ulcer disease. Okay, so we have to just give a bit of context. Peptic ulcer disease is a product of an imbalance between the good and the bad. So now, what is the good and the bad? The good is all the defense mechanisms that we have in our stomach. And the bad is all the things that hamper those defense mechanisms. So now what do we have in our stomach? We have the stomach acid. We have mucus layer, and we have prostaglandins, which are protective mechanisms. There are a lot of others as well, but these are the protective mechanisms. We also have tight junctions, epithelial barriers. However, the main thing comes down to the protection of the mucus layer from the acid and the usage of prostaglandins, which increase this mucus layer or increase the mucus and bicarbonate production and decrease the increase the blood flow to the circulation. Just 1 second. Okay, sorry about that. So when these defense mechanisms get hampered in any way, such as if we have an H. pylori infection, if we use NSAIDs, if we have increase in gastric acid, such as if we have a gastrinoma, Zollinger-Ellison syndrome, right? If we have H. pylori infection, as I mentioned, all of these factors can hamper the balance between the defense mechanisms and the aggressive factors. Right, so this brings me to one of the most important pathways, which is the cyclooxygenase or the COX pathway. Now, what happens here? So we have arachidonic acid, and then we have the COX enzyme 1, COX enzyme 2. COX enzyme 1, it produces constitutional prostaglandin. What does this mean? It keeps up continuous production of prostaglandin, which is good for our body. But COX-2 produces prostaglandin only in cases of inflammation. So when we have an inflammatory stimuli, such as the inflammatory interleukins 6, 8, or any trauma, such as in cases of peptic ulcer or H. pylori infection, we want to produce COX-2 enzyme. So that is on top of COX-1. COX-1 is constitutional, so it is always produced. Okay. Now, the protective factors that the COX-1 produces is inhibited by the traditional NSAIDs. So ibuprofen, what do we have? Diclofenac, indomethacin, all of these NSAIDs inhibit the production of gastric protection, or PGI2, or prostaglandin, that is responsible through the COX-1 pathway. So not only does it decrease the effects of inflammation, it inhibits both of these pathways, right? COX-1 and COX-2. So not only does it decrease the inflammation that is caused extra through any kind of insult, such as trauma or infection, it also decreases the constitutional COX production. Now, what happens over time? Over time, you have decrease in prostaglandins, and this causes decrease in mucus production and decrease in the blood flow to the stomach and the duodenum, or the GIT in general. What does this do? If we have decrease in blood flow and decrease in mucus production, we have increase in the amount of damage that the stomach acid is able to do to the lining of our GIT. If we have increase in the damage, we have an increased risk of ulcer formation. All right. In other conditions, on a better note, I would say some selective NSAIDs, such as celecoxib, the name suggests it, selective COX inhibitor, basically. So celecoxib, it only inhibits COX-2. COX-2 is produced only in cases of inflammation, so this only inhibits the inflammatory prostaglandin that is produced. So this is said to be better in terms of gastric protection. However, it has other side effects, and it cannot, sometimes it cannot be used alone, or using it alone is not really effective. Okay, so that's kind of the context of what's going on here. So when we have damage caused by NSAIDs or by H. pylori infections, that is when we have peptic ulcer disease. Peptic ulcer is essentially any break in the gastric or duodenal mucosa that extends through the muscularis mucosa caused by acid injury, which is overwhelming the mucosal defenses. The most common cause worldwide for both gastric ulcers and duodenal ulcers is H. pylori infection, and the second most common is NSAIDs. Okay, since H. pylori infection is the most common, just a bit of context about it. H. pylori is a gram-negative organism, and it is a urease-producing organism. Now, when you ingest H. pylori, what happens? You have the H. pylori using its urease, to break down urea and form ammonia. Once it forms ammonium, it coats itself in a layer of ammonia. What does this do? When it has a layer of ammonia, which is alkaline, it stops itself from getting affected by the stomach acid. Okay, so this is like pure chemistry. So the hydrochloric acid neutralizes with the ammonia layer that the H. pylori organism has surrounding it. And this protects itself, the bacteria itself, from getting eaten or getting dissolved by the acid. Then it can invade the gastric mucosa and populate there, basically. So it invades the gastric mucosa and bypasses the acid production. All right. Okay, so this is just a snippet from step 1 book. Oh, sorry, first aid book. Yeah, so gastric ulcers, it gets worse with meals. However, duodenal ulcers decreases with meals. This is because gastric ulcers are, so when you have meals, your stomach production is stomach acid production is increased. However, when you have a duodenal ulcer, this is the opposite that's happening, because when you have more food, the food dilutes the acid, and the food that goes to the duodenum is less acidic, if that makes sense. So food makes duodenal ulcers feel better, but gastric ulcers worse. All right? Okay. So now that we know the mechanisms and why these peptic ulcer disease happens, so why this happens, we know what exactly to target. This is our main goal in pharmacology. We need to target something that is wrong. So either we can decrease the acid production, which is causing the insult in peptic ulcer, or we can increase the protective barriers, or we can eradicate the infection in the most common cause of the peptic ulcer disease, which is H. pylori. I said or, but it's not really or. It's kind of a combination of all of these treatments that is usually given. Okay, so now first we want to decrease the acid production. How can we do that? This is the second histaminic receptor antagonist that is coming in our lecture. So this is H2 receptor antagonist that is involved in the production of acid. So famotidine, nizatidine, cimetidine. And there was ranitidine. I remember when we took, yeah, I believe when we took, no, never mind. But ranitidine was like one of the drugs that was used, but now it's withdrawn. So remember that. You can remember that ranitidine ran away, basically. Okay, so these drugs are used and they antagonize the H2 receptors in parietal cells, and therefore they don't let hydrogen ions, sorry, acid to be produced. So they decrease the release of CAMP and prevent the hydrogen potassium ATPase so that the acid production is reduced. It is a second line of medication, and it is used PRN for breakthrough acidity because when we'll take another class of drugs, you'll see, which is proton pump inhibitors, we'll see that those take a few days to take effect. And when you have breakthrough symptoms, you will go to the H2 receptor antagonist, basically. Okay, so now the side effects are headaches. I think I forgot to include some more, but it's headaches specifically. And one thing we need to remember about cimetidine is its CYP inhibition. So it increases the effect of other drugs. In other words, it decreases the effect, decreases the metabolization of other drugs. So this is very, very important to keep in mind. So when you see a question that says a person with long-term history of GERD takes medications, however, no, let's say a person with a lot of comorbidities. So he has hypertension, diabetes, takes medications for all of them, recently started taking medication for GERD. And then they might mention that GERD or like peptic ulcer. Then they might mention that, oh, recently he's been feeling hypoglycemic or basically any symptom of an overuse of a medication that he's been taking. So then you have to think that, okay, something is not letting the drugs that he's taking to be metabolized. And this is cimetidine, which is usually the culprit. Okay, so then we have antacids. I couldn't really find much about antacids in the slides, but I remember we took them in kind of kind of in detail. So I'll just mention a few pointers. So the main antacids that we use are calcium carbonate, sodium carbonate, magnesium hydroxide, and aluminum hydroxide. And it increases the pH. It's basically, it antagonizes the acid or neutralizes the acid, right? Aluminum, so side effects, you need to remember that aluminum causes constipation, magnesium causes diarrhea. How do we remember this? Two ways. So magnesium, we'll see it later in the in the laxatives as well. So you can remember it from there that it causes diarrhea. And also you can remember from a very stupid mnemonic, which is magnesium magnifies stool. Okay, so magnesium magnifies the stool. So it makes more stool and yeah, so it causes diarrhea. Okay, all right. Then we have proton pump inhibitors. I wish the diagram would load. But anyway, please ignore this horrible diagram. Anyway, the gist of what I'm trying to say is the next class of drugs, basically, so which is called proton pump inhibitors. So we took the H2 receptor antagonist, as you can see here. It prevents the histamine from binding and prevents the uh, production of CAMP or cyclic AMP. And this inhibits the production of hydrogen potassium ATPase. And thus you have decrease in acid production. Proton pump tackles it from another way. It directly inhibits the hydrogen potassium ATPase and therefore reducing the acid production. Okay. All right. So now, proton pump inhibitors, they're prodrugs. So they're taken in as zymogens, if you remember that word. It's basically not an active form. So it goes to the body and then it's metabolized in active form. Examples include omeprazole, esomeprazole, pantoprazole, lansoprazole. And it causes irreversible covalent bonding to hydrogen potassium ATPase. Because it's irreversible covalent bonding, this is why you will have a very long-term side effects, because it will take a while for the stomach to regenerate the hydrogen potassium ATPases, right? The instructions is to take it 30 to 60 minutes before meals so that you can have the maximum amount of acid that can be kind of inhibited. And the full effect takes 3 to 5 days. It is irreversible covalent bonding. However, since those are prodrugs, it takes a while for them to be metabolized and the full effect to take place. This is why we use those H2 receptor antagonists for breakthrough ones because they have a faster onset of action. And these take 3 to 5 days. So for acute acidity, this is not the drug that you will prefer. Okay, but long duration of action and a very, very good efficacy, about 99% from what I've seen in the slides. You need to remember drug interactions such as clopidogrel, methotrexate, pH-dependent drugs. And side effects, it can be short-term and long-term side effects. Generally, it's a very well-tolerated drug. However, short-term, it can cause nausea, vomiting, headache, abdominal pain, and dizziness. Long-term, it can cause C. difficile infections, hypomagnesemia, and B12 deficiency. So now, let's make sense of it so that we can remember it. Now, acid production, it is there for a reason, right? It is there to digest food, it is there to facilitate absorption of food, and it is there to prevent infections. Now, if we have a drug that causes long-term suppression of these acids, what are we going to do? We're going to allow infections to occur, right? So that's why we have increased risk of superimposed infections, such as C. difficile infection or opportunistic infections, such as C. difficile. And we're going to have decrease in minerals and decrease in stuff that we actually need to absorb. So this causes hypomagnesemia and B12 deficiency. All right, so B12 deficiency, it will present with neurological symptoms, anemia symptoms on, what do you call it, on blood tests. You'll see macrocytosis, you'll see increase in MCV, and neurological symptoms because of the subacute degeneration of the spinal cord. And hypomagnesemia, it will present with muscle cramps, heart defects, heart arrhythmia, such as torsades de pointes. And you can treat them with magnesium sulfate, basically. Okay, so vonoprazan, this is, we did not have this drug, to be honest. This was my first time seeing this drug. It is essentially the same mechanism of action, but instead of irreversible, this is potassium competitive acid blocker. So PCAB, that's the name of the drug. So it is not a prodrug, hence it has a higher, faster onset of action. The full effect takes 1 day. There's no food restrictions because we don't really care. It's a competitive acid blocker, and it has better nocturnal control. So it's basically better. That's why it was developed later, right? But the only catch is that it's more expensive. So for PPIs are still the standard of treatment, but there are new drugs which have a faster onset of action, no food restrictions, and no instructions as to when to take it before meals or after meals. And they are competitive acid blockers of the hydrogen potassium ATPase. However, they are more expensive. Okay, now we finished decrease in acid production. We want to tackle peptic ulcer from another mechanism, which is by increasing mucosal protection. Now, how do we increase mucosal protection? We can either increase prostaglandins, which facilitate mucus production and bicarbonate secretion. We can have something that coats the ulcer so that it forms a mucus by itself. Yeah, those are the only two ways. Yeah. So prostaglandin analogs such as misoprostol is used to increase the mucus production and increase the blood flow to the ulcer, essentially. So ulcers form when you have no protection and the acid is eroding the lining, and when you have decrease in what do you call it? Vasculature, right? So decrease in blood flow, ischemia leads to ulcer. So this is why diabetic patients have ulcers. Arterial insufficiency has ulcers, right? So we need to use prostaglandin analogs. However, very, very, very important is that it is contraindicated in pregnancy. This is very important because prostaglandin in pregnancy can induce abortion, right? So prostaglandin causes uterine contractions. So we don't want to cause uterine contraction at 18 weeks of pregnancy, obviously, right? So misoprostol is used given that the patient is not pregnant. Very important. This shows up a lot in exams. Then we have something called sucralfate. It is a polymerization. It causes polymers and it forms a viscous gel. Sorry, it says viscous, but it's a viscous gel which binds to the ulcer and it coats the ulcer. It should be taken on an empty stomach, and side effect will be constipation. This makes sense to remember because sucralfate, anything that forms like a gel layer, viscous gel layer, is going to be hard to excrete, right? So this hard to excrete thing is going to cause constipation, definitely. Then we have bismuth. Bismuth also coats the ulcer, and it is bactericidal as well. Side effects, it can cause black tongue, neurotoxicity. How do I remember black tongue? You can remember bismuth, mouth, black mouth, basically. Okay? Yeah, that's the best I could come up with. Now, We decrease acid production, we increase mucosal protection, but we want to target the main culprit of most peptic ulcer diseases, which is our H. pylori. To eradicate H. pylori, there are different types of therapies that are used. The most preferred therapy nowadays is going to be the quadruple therapy. Back in the days, we used triple therapy as the preferred mechanisms. However, because of clarithromycin resistance, which is one of the drugs that is used in triple therapy, people have now switched to quadruple therapy because this therapy is really abused. It's not completed to completion, and clarithromycin resistance is really high nowadays. So this is very important that completion of therapy is very, very important in order to decrease the incidence of resistance. All right, so the preferred therapy nowadays is the bismuth quadruple therapy. And what drugs do we use here? We use a PPI, we use bismuth, tetracycline, and metronidazole. So PBTN. Very stupid mnemonic again, peanut butter trademark. So P for PPI, B for bismuth, T for tetracycline, and M for metronidazole. Okay. Alrighty, so we use this for 14 days, and eradication rate is about more than 90%, and this is not affected by clarithromycin because we're not using clarithromycin, we're using tetracycline and metronidazole instead. If, for information, we really had to know the triple therapy, but yeah, I guess for you guys, quadruple therapy is the most preferred option, even in the slides. Alternatively, instead of the PPI, we can also use vonoprazan. Again, what do you remember about vonoprazan? It's not a prodrug, faster onset of action, and it is a PCAB, potassium competitive. What's it called? Potassium competitive blocker. Sorry, potassium competitive acid blocker. Okay, so that's the alternative. Another alternative is amoxicillin and rifabutin, but I've not seen this being asked. So remember the quadruple therapy, sometimes you can substitute the PPI with vonoprazan, but in that case, we'll only use amoxicillin. Okay. Another thing is that after this therapy is taken, we need to follow up with the patients to make sure that H. pylori is truly eradicated from their body. How do we do this? We use urea breath test or stool antigen test. But you need to remember when to use these tests. So when the patient takes antibiotics, we need to wait for 4 weeks after the completion of antibiotics to undergo either urea breath test or stool antigen test to see whether the H. pylori is eradicated. And we need to do it after 2 weeks if they only take PPI. Now, we use urea breath test or stool antigen test to confirm eradication because it is the least invasive. It's just breath or stool. We don't really use blood tests such as PCR or all of that because these are less invasive and they're sensitive as well. Alrighty, so that brings me to the end of peptic ulcer disease. Let's do a few questions. So, a patient on long-term treatment for heartburn develops muscle cramps and ventricular arrhythmias. What electrolyte abnormality is most likely? That is going to be hypomagnesemia, right? C. What drug are they taking? They're taking PPIs. Hypomagnesemia, what ventricular arrhythmia are they talking about here? Perhaps Torsades de Pointes. Okay, next question. A woman with chronic NSAID use develops gastric ulcers. Which drug prevents ulcers by increasing mucus and bicarbonate secretion? It's going to be misoprostol. Misoprostol is a prostaglandin analog that increases gastric acid secretion. Oh my God, mucus and bicarbonate secretion. All right. NSAID use develops gastric ulcers. How? By inhibiting the COX-1 pathway, which produces prostaglandins. Right. So if you have decrease in prostaglandins, you'll have increase in the amount of damage that the acid can do to the stomach. All right. Patient with multiple medical problems taking several drugs, including theophylline, warfarin, quinidine, and phenytoin. Despite the likelihood of interactions, dosages of each are adjusted carefully so that their serum concentrations are acceptable. However, the patient suffers some GI distress and starts taking a drug provided by one of his well-intentioned friends. He presents with excessive or toxic effects from other medications, and blood tests reveal that their serum concentration is high. Which was the drug that is most likely self-prescribed? It's going to be cimetidine, right? Yes, it is going to be cimetidine. What is a class of drug? It is an H2 receptor antagonist. Right, so always with cimetidine, you need to remember the CYP inhibition, which increases the risk of other, um, increases the effect of other drugs. All right. Which drug causes dark stools and tongue discoloration? Bismuth. Yes. So bismuth is something that coats the ulcer and also is bactericidal. So bismuth, black stool, and black tongue, and also bactericidal, all with B. B, 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 B. Okay? All right. That's peptic ulcer disease. If you have any questions, let me know. We'll move on to the next lecture, which is laxatives and anti-diarrheals. Here we will tackle two main problems, constipation and diarrhea, both very common symptoms. For constipation, which is unlike diarrhea, the most common cause of constipation is actually functional or dietary related constipation, whereas for diarrhea, there is almost always an underlying cause. Therefore, for constipation, we need to, of course, treat the underlying cause. However, we treat more of the symptoms. However, we also should investigate further for secondary underlying causes. So what can cause constipation? It can be because of hypothyroidism. It can be because of drugs, such as the anticholinergic drugs. It can be, what else? It can be because of tumors, I guess. Yeah, an obstruction that can cause constipation. It can be, or it can be because of functional constipation, which can be because of dehydration or lack of intake of fiber in the diet, right? So that's why we start off with non-pharmacological treatment, and this is very important. So if someone comes in with mild constipation, we can suggest to them the lifestyle modification, which is increase in fiber intake. So increase in whole foods or whole grains, increase in water intake with the fibers will relieve constipation. Right, then we move on to pharmacological treatment, and there are 5 classes of laxatives that we'll be discussing. So we have the bulk forming laxatives, osmotic, irritants and stimulants, stool softeners, and lubricants. Okay, let's begin. Okay, so bulk forming laxatives. What do? As the name suggests, they form a bulk. And if anything forms a bulk in the GI, it distends the GI, right? So if they distend the GI, they will stimulate peristalsis. So this is the main mechanism, basically. So bulk forming laxatives can be naturally forming or synthetic. Naturally forming could be psyllium, bran, ispagula. So these are things that you also hear your mom saying sometimes, like the ispagula and bran, which is a whole grain, right? But there are also some synthetic ones, such as methylcellulose and polycarbophil, calcium polycarbophil, and these are synthetic bulk forming laxatives. What is the mechanism of action? Very simple. It forms a bulky hydrated mass. So you need to drink it with water for sure, because if you just take fiber, it's going to get stuck in your stomach, right? But if you take it with water, it's going to be a hydrated mass that is easily moving through the intestines, and it stimulates peristalsis, a GI distension, and ultimately defecation. And interesting thing about laxatives, bulk forming laxatives, such as psyllium, is that it can be used both in constipation and in diarrhea. Why is this? Because because think about the mechanisms of both. So constipation is when you cannot stimulate peristalsis, right? And diarrhea is when you can stimulate no, let me rephrase what I'm saying. So constipation is when you cannot stimulate enough peristalsis for some reason, or if the stool is very hard and you cannot stimulate peristalsis. Chronic watery diarrhea is when you also cannot stimulate peristalsis, but not because it is the diarrhea itself. Uh, Actually, I don't know. I'm confusing you and myself. So constipation, we use bulk forming laxatives because we want to form a mass that is enough to cause GI distension and that is hydrated enough to pass through the GI. Whereas if we have diarrhea, we want to bulk up the diarrhea a bit because then it will become less diarrhea, if that makes sense, right? So we want to form a bulk so that it becomes a normal stool consistency. Therefore, psyllium can be used in both constipation and watery diarrhea. However, you need to use psyllium or any other bulk-forming laxative with water to prevent one of the side effects, which is intestinal obstruction, right? If we form a very big bulk in our colon, it can get obstructed. And this can cause cramping, nausea, vomiting, flatulence, etc. The onset is 1 to 3 days. One way to remember bulk is psyllium is just to remember that Hulk is silly. Okay, so Hulk is bulk, silly is psyllium. All right. Okay. Then we move on to osmotic laxatives. These include magnesium citrate, magnesium hydroxide, lactulose, and polyethylene glycol. What do? They draw in water into the into the GI, so they're osmotics. They draw in water, and they increase the intestinal activity. Now, um, lactulose is a very special drug that is used in another place that you will see in the future, but it is essentially an osmotic laxative. And it is broken down by disaccharide sugar it is disaccharide sugar that is broken down by the colonic bacteria. And when this happens, you have colonic distension, right? Because it is broken down into gases, lactic acid, and acetic acid. Okay, so further, I'll discuss the mechanism of action of lactulose further as well. But in regards to just the functioning of laxatives, this is what lactulose is. Indications is that it is used in constipation, second line for constipation, and for preparation of surgery. All right. Side effects can include hypermagnesemia, cramping, and bloating and diarrhea. Hypermagnesemia because the drugs that you can see here, magnesium citrate and magnesium hydroxide. Okay. Polyethylene glycol has less cramping side effects than others, and lactulose decreases the fecal pH. How do we remember this? These are just some special things to remember. Lactulose is broken down into lactic acid and acetic acid by the colonic bacteria, and this is why you have decrease in the fecal pH. If you remember, I believe it's kind of the same thing that people with lactose, what do you call it? Oh my God, I have it and I can't think of the word disease. Basically, people who can't digest lactose, they also have decrease in the pH of their stool and their breath as well. So that's one of the ways we can diagnose lactase deficiency, actually. Yes. So this is also one connection that you can make. Polyethylene glycol has less cramping side effects, so it's more commonly used than the others. And that's it about osmotic side effects, the second line of usage. Then we have stimulant and irritant. So these drugs, what do? They stimulate peristalsis. All right. Now, these drugs are bisacodyl, sinusoids such as senna, and also castor oil. Their mechanism of action, as I mentioned, is to stimulate peristalsis. Indication is constipation third line, and also preparation for bowel surgery, as with the other laxatives as well. And side effects could be lazy bowel. So if you stimulate the bowel too much or irritate the bowel too much, you can have resistance to it. So the bowel just does not listen to you, basically. So lazy bowel and also hypokalemia. Yeah, I believe the mechanism of hypokalemia is because of decrease in absorption of potassium. However, I'm not sure about it, but I believe that's the mechanism. Yes. So the next two classes of laxatives are stool softeners and lubricants. So stool softeners include docusate sodium and docusate calcium, and they are agents that are active and they emulsify the stool. So once you emulsify the stool, it essentially becomes softer. Okay, so indications would be hemorrhoids, fissures, anything that makes the stool very painful to pass. So, you took in GIT, anal fissures, and hemorrhoids. So these people have a very difficult time passing stool. So for those, we can give them stool softener so that they can pass the stool, but the stool is way softer. Side effects will be cramping and diarrhea again. Yeah. So any side effect for laxatives is going to be diarrhea, which is the opposite extreme of constipation. Okay. For stool softener, a very interesting way to remember is that soft people don't cuss. This is not necessarily true, but just make it true for this case. So soft people don't cuss. So Docusate, don't cuss, soft. So stool softener. I hope that makes sense. Okay, next we have lubricant. It is just facilitating the passage of hard stool, just lubricates the area. And we can use mineral oil and glycerin suppositories. And main thing to remember here is that if you take mineral oil while you are lying down, you can aspirate it instead of ingesting it. And this will cause something called lipoid pneumonia. So to prevent this aspirational lipoid pneumonia, you should take it while sitting upright. Okay? All right, so this is again a comprehensive summary from the first aid book. You can use this for your reference. Okay, now diarrhea is, as I mentioned, different to constipation because it almost always has an underlying cause. These underlying causes could be infections, most commonly, so gastroenteritis, food poisoning, malignancy, such as carcinoid tumors, anything that causes excessive serotonin, right? It can cause diarrhea. Drugs. What drugs can cause diarrhea? Overuse of laxatives, for sure. Any cholinergic drugs, anything that stimulates the parasympathetic nervous system a lot can cause diarrhea, right? Then hormonal causes, and there are three types of diarrhea: inflammatory, secretory, and osmotic. So secretory is, as you can say by the name, anything that secretes toxins, secretes NaCl and H2O into the lumen. Okay, so bacterial toxins inhibit the ability to absorb sodium chloride. In other words, they have more sodium chloride and water in the lumen, and this is secretory diarrhea. Osmotic diarrhea is because of poorly reabsorbable substances that you might have in the lumen that draws in more water. Okay, osmotic is essentially just drawing in more water. And inflammatory is because of infection or any kind of microorganism that is causing inflammation, and this causes more water, more inflammatory molecules to be collected in the lumen. So these are the three main causes of diarrhea. Diarrhea prevents, what are the steps of management? So first of all, diarrhea means you're losing a lot of water. So what do you want to do? You want to replenish the water. So how do you do this? You do this by oral rehydration therapy. So in cases of mild diarrhea, what you're going to see the patients say, what you're going to see the doctors do is first they'll give them oral rehydration. I remember this story that we were taught that when there was a huge outbreak of cholera, oral rehydration therapy was actually one of the biggest breakthroughs in treatment. Just oral rehydration. So oral saline, basically. Yeah, so that's how you can remember. And then you start treating the symptoms by anti-motility drugs such as difenoxylate and atropine, loperamide, and adsorbents such as diastop, kaolin, and pectin. Again, these are just some stuff to memorize. And after that, obviously, you have to treat the underlying cause, whether it be infection, malignancy, drugs, hormonal, etc. All right, so oral rehydration solution is the first line treatment. After that, we move on to difenoxylate and atropine, and these are opioid agonists. So they treat the diarrhea in given that the patients are 13 years or older. And you can remember this by thinking that, okay, I don't want to give opioids to young children, okay, because of the risk of abuse. Okay, atropine is often taken with the difenoxylate to prevent abuse of these drugs because they can get addictive or people can start relying on these drugs. So it is used for acute diarrhea, diarrhea predominant IBS, but it is not used for infectious diarrhea. Okay? So it blocks the acetylcholine release, decreases peristalsis, and this is how we decrease the GI motility. However, it does not have the analgesic effects of morphine, but at higher effects, it can cause euphoria and CNS effects similar to other opioids. Okay. Then we have other anti-motility drugs such as loperamide, which is used commonly, such as Imodium. And it inhibits peristalsis. However, it does not cross the blood-brain barrier, so it does not have the CNS toxicity effects, and it has no analgesic properties. Okay, or potential for addiction, which is why it is used more commonly. It is preferred over difenoxylate atropine because of its greater efficacy and also better tolerance and less chances of abuse potential. However, side effects of a drug for diarrhea is obviously going to be the opposite end, which is constipation, drowsiness, and dry mouth as well. Okay, complications can be electrolyte imbalance. So this is, I believe, because of the imbalance between what you're losing and what you're having, right? So, what can happen is sometimes you're stopping the water from being lost, but you can't stop the electrolytes being lost. So this causes a imbalance in the electrolytes. Then you can have something called toxic megacolon. I believe this is because if you decrease the GI motility, you allow more infections to take place in the GIT. And over time, this can lead to C. difficile infection, it can lead to toxic megacolon, or even stopping the GI motility itself can cause toxic megacolon, which is just a megacolon that doesn't respond or doesn't defecate. So you have accumulation of feces, basically. Okay. Adsorbents. They're stuff that kind of sticks to the bowel, they coat the bowel, and they increase the stool consistency, so it makes the stool more firm. And they also adsorb or attach to bacteria and toxins to cause these effects. All right, so most commonly used is kaolin and pectin. And it causes another drug such as diastop is used as well, which contains calcium carbonate. And kaolin thickens the stool. Okay, so kaolin mostly it is used to thicken the stool, whereas diastop it is mostly used to coat the bowel. Okay, so it causes decreases adsorption or absorption of other medications, so we need to keep that in effect. Sorry, keep that in mind when we prescribe other medications while the patient is on adsorbents, because if there is a thick lining of the GI or the intestines, you'll have decrease in absorption of other drugs, right? Specifically, digoxin, clindamycin, and tetracycline. Okay. Other drugs such as bismuth, we are seeing this again here. Bismuth can be used. It is anti-inflammatory on the bowel. It is also bactericidal. As we mentioned, it's often commonly known as Pepto-Bismol. Other things such as probiotics can be used to cause antibacterial effects. So if we introduce good bacteria, sorry, if we introduce good bacteria into the gut, such as lactobacilli, we will have removal of the other bacteria, which are not as good. And this will cause antibacterial effects. And rifaximin is used in traveler's diarrhea. I believe this is coming up in another part of the lecture as well, where I'll be talking more about it. So that brings me to the end of laxatives and anti-diarrheals. Let's do a few questions to test ourselves. Which of the following can be used in both constipation and diarrhea? It is the silly drug, which is psyllium husk. Okay, it is what kind of laxative? It is a bulk laxative. Okay. Then, a patient with chronic constipation started on psyllium but develops abdominal pain and bloating after poor water intake. What complication has occurred? So here, the complication is going to be intestinal obstruction, because it makes sense. If we want to take something that forms a bulk without giving it hydration, it's just going to be a bulk that is stuck in the GI, right? So this can cause obstipation or complete intestinal obstruction. Okay, which laxative works by increasing stool water via non-absorbable solutes? So essentially, it is something that draws in more water, and those are the osmotic laxatives, such as lactulose. A patient with acute infectious diarrhea presents with fever and bloody stools. The best initial management is going to be what? As I mentioned, before you give drugs, you need to make sure you replenish the water that they're losing with the diarrhea. That is going to be oral rehydration solution. One thing that is not really, it's kind of out of the scope of the lecture, but since it's bloody stools, you obviously have to stabilize the patient as well. Maybe they're losing a lot of blood, so you have to do ABCs, check if their hemoglobin is low. Maybe you have to transfuse blood. But yeah, for the sake of this lecture, anyone who presents with mild dehydration and continuous diarrhea, you have to give them oral rehydration solution. In severe cases, you might also give them IV bolus of fluids. Okay, now we move on to the second last lecture, I believe, which is drugs used in viral hepatitis. This is going to be a lot of names and a lot of fancy names, which are difficult to remember. But inshallah, let's go through it together. Let's do a few questions just to make ourselves familiarized with the drugs. Okay. All right. So viral hepatitis mostly focuses on hepatitis B and hepatitis C because hepatitis A doesn't really require any kind of treatment, and the D and E are different kinds of drugs. So one key difference between hepatitis B and hepatitis C is that acute hepatitis B does not require treatment because it is self-resolving. It is the chronicity, which is more than 6 months of infection. So even after 6 months, you can see that HBs antigen is still positive. That's when you will start treatment. Okay? However, hepatitis C requires treatment as well. Okay. However, hepatitis C requires treatment in the active infection to prevent chronicity. So the drugs used, I just listed them here just so you can have a perspective of what's going on in the lecture. So the drugs used in hepatitis B are interferons, tenofovir, adifovir, lamivudine, and entecavir. Drugs for hepatitis C are also interferons and ribavirin. However, they have direct-acting antivirals that directly affect the replication cycle of the hepatitis C, and these are NS3 and NS4 inhibitors, NS5 inhibitors, which can be NS5A or NS5B. All right, let's begin with the hepatitis B drugs. Okay, so hepatitis B drugs, first of all, we have interferon. So interferons, they're naturally occurring in the body in cases of inflammation and infection, and they and they're protective for antiviral infection specifically. So what we do is we give them an additional amount of interferon and something called pegylated or peg interferon formulation. So there are three types of interferon, alpha, beta, and gamma. Most commonly in hepatitis B patients, we give this. What is this? Peg interferon alpha 2A. What does this mean? So it is interferon alpha and it's pegylated. Pegylated means that it is added to other stuff to increase the weight of this interferon so that it is absorbed in a greater amount of time. So the duration of treatment and the duration of effect of the treatment is increased. Now, what do interferons do? It increases basically what you would expect our inflammatory markers to do in any cases of infection, right? So it heightens antiviral defenses, enhances phagocytosis, inhibits viral replication, and increases cytotoxicity. So we are enhancing phagocytosis. So engulfing of the virus, we're increasing cytotoxicity, and we're inhibiting replication of the virus. So we're really tackling it from all sides. However, side effects, when we get an infection, we get fever, we get flu-like symptoms because of these cytokines and interferons. So it makes sense that when we take interferons, we need to think about flu-like symptoms. We might get flu-like symptoms such as fevers, chills, myalgias, and also dose-limiting bone marrow suppression. So if you decrease the dosage, the bone marrow suppression is going to subside. However, if the more dosage of interferon that you give, the more bone marrow suppression that you're likely to have. Now, why does this happen? You can make sense of it because when we increase interferon, we increase the demand of our blood cells. So we increase the demand of white blood cells to make more and more so that they can fight off more infections because of these interferons, which stimulates the white blood cells, and this can ultimately cause bone marrow suppression. Okay. However, you need to remember that it is contraindicated in some conditions which are very important to know, such as autoimmune disease, psychosis, pancytopenia, and decompensated liver cirrhosis. I make sense of it as since interferons are part of the immune system, we don't want to give it when there is already too much of the immune system. What is the circumstance? Autoimmune disease. Right, so in autoimmune diseases, you have too much of the immune system, and this, if you give even more of the immune system through cytokines, interferons, whatever, this will only worsen the condition. Another interesting one is decompensated liver cirrhosis. I can't really think of a mechanism, but I believe it's similar to the autoimmune disease as well. So you don't want to increase the autoimmune injury of the liver. Okay, so maybe it might further cirrhotic complications. All right, so that's my interpretation. Then we have other drugs as well. So we have lamivudine, adifovir, tenofovir, and entecavir. I just wanted to give a disclaimer on the drugs. I know for a lot of these slides, you might see that it's way less than what's there in the lecture. I believe I included what is important to know for the exam. Doesn't necessarily mean that everything is going to come from this, whatever I have specifically, because it really depends on the doctor and what they want to include. But I believe everything that's high yield, everything that should be tested is in my lecture. So let's start off with lamivudine. Lamivudine is a cytidine analog, so that's how you can remember, cytidine analog, inhibitor of both reverse transcriptase and DNA polymerase. Now, all of these drugs, as you can see, they are analogs. What do analogs do? They form a decoy, or they're basically like traitors. So they incorporate themselves into the enzymes or the DNA chains, and they incorporate them. However, after the DNA takes them in, they cannot continue the chain further because they are not the same um, molecule as cytidine. It is a cytidine analog or an AMP analog or a nucleoside analog, right? So they start off by being like, oh, I want to be friends with you, let me join you. But then they just terminate the DNA chain, if that makes sense. So lamivudine is a cytidine analog. It inhibits reverse transcriptase and also DNA polymerase, and it's a generally well-tolerated drug. Adifovir is an AMP analog, so adenosine monophosphate analog, as you can see from the name. And it is phosphorylated by cellular kinases. I doubt that they're going to go into so much details. However, you can just remember that they're phosphorylated. Yeah, so you can remember that it's phosphorylated because it's AMP, and usually we have ATP, which is triphosphate. This is only monophosphate. So you can imagine that in the cells, you'll have kinases which phosphorylates it more, and this causes it to inhibit DNA polymerase, which causes termination of the DNA chain. However, it does cause nephrotoxicity. Very, very important to know. Tenofovir is converted to diphosphate, which is then converted to deoxyadenosine triphosphate, so deoxy-ATP essentially, and this again incorporates into the viral DNA, causing termination. All right, so it's a very common theme here. Just remember the analogs that they are. So lamivudine is cytidine, adifovir is AMP, tenofovir, it is converted to 5-deoxy-ATP eventually, and entecavir is a nucleoside analog. Okay, coming back to tenofovir, it is the preferred agent in pregnancy. Okay, because of decrease in teratogenicity compared to the other drugs. You can think of it, you can remember it by 10 of us or tenofovir. So imagine a cat that's like pregnant with 10 baby cats, right? So there are 10 of us and we can only take tenofovir. However, in severe cases, it can cause lactic acidosis and hepatomegaly. All right, okay. So I just remembered that tenofovir, so 10 of us, pregnancy. So sometimes in pregnancy, and not sometimes, you always have a big stomach. What is another cause of big stomach? It is hepatomegaly. So that's how you can remember. In pregnancy, you can take tenofovir. However, it will give you a big stomach because of the pregnancy and also because of the hepatomegaly, right? Okay. Then you have entecavir, which is a nucleoside analog. And if you remember, nucleosides are a bit different than nucleotides because of the phosphate. So nucleoside plus the phosphate makes a nucleotide, right? So this is a nucleoside analog, and it is to treat acute on chronic. So chronic hepatitis B, if they have superimposed acute hepatitis B infection, you can give them entecavir. However, it causes hyperglycemia, which is very, very important to remember as well. Now, a very silly way to remember hyperglycemia is in Arabic, you can say, this will sound a bit mean, but you can say enta kabir, such as like enta kabir. So you're big, so you have diabetes or hyperglycemia. I'm sorry, it sounds insulting. Enta kabir, enta kabir because of hyperglycemia. Okay, sorry if that sounds mean. So as you can see through with this fat cat here. Okay, so resistance to one drug reduces the effect of other drugs. As you can see, these are all very similar mechanisms of actions in that they all are analogs that terminate DNA chain. So if you have resistance to one drug, so if the virus figures out to bypass one of the pathways, it decreases the effect of all of the other drugs. This just goes to emphasize how important it is to take treatment to completion and to not take things lightly, basically. Now we're moving on to hepatitis C. Hepatitis C drugs, you have the interferon and the ribavirin. However, more importantly, you have the direct-acting antiviral agents. And these target various points within the hepatitis replication cycle. So this is the the structure of the hepatitis C. And you can see that at various points, you have coding of various different genes. So you have metalloprotease, which is NS3. You have serine protease, which is NS4A. So both of these are proteases. Then you have NS5A, which is interferon resistance protein, and then NS5B, which is a polymerase protein. Okay, so remember these. And you can remember them easily because NS3 and NS4A inhibitors are called protease inhibitors. And then you have NS5A, which is, I believe, replication complex inhibitors, and NS5B, which is a polymerase inhibitor. Okay, so that's how you can remember these. All right, so just one slide on everything. Ribavirin is a guanosine analog. So again, it's an analog. It inhibits the RNA-dependent RNA polymerase. So ribavirin, R for ribavirin, R for RNA-dependent RNA polymerase inhibition. Okay, I wish I could have a mnemonic to remember that it's guanosine, but I couldn't think of anything. If you think of anything, just let your colleagues know, please. Okay, so it is used in combination with either interferons or direct acting antivirals. So coming to the direct acting antivirals, we have three types. We have the NS3, NS4A protease inhibitors, we have the NS5A replication complex inhibitors, and we have the NS5B polymerase inhibitors. We can recognize these drugs by how they end in. So the the protease inhibitors, which is NS3 and NS4A, end in privir, which is P for protease, P for privir. Then NS5A for asvir, NS5B for buvir. Very easy. These are all you need to know for hepatitis C. So remember that ribavirin is a guanoside analog. R for ribavirin, R for inhibition of RNA-dependent polymerase, RNA-dependent RNA polymerase. Then you have direct-acting agents. 3, 4A is protease, so privir. Then you have 5A, which is asvir, and B, which is buvir. Okay, there are the last three slides, which the doctor says that you don't have to know the names of the drugs specifically, but you need to know the combination, essentially. So the 3, 4A is combined with 5A, so the A's are combined and used as a drug to increase the efficacy or potency. And then there is another one that combines all three of them. So you can see asvir, buvir, and privir. Okay, speaking of asvir, one of the ones specifically is ledipasvir. Its absorption is decreased at a higher pH. So patients who take antacids or proton pump inhibitors for a long term may have decreased absorption of these drugs. So you just need to keep that in mind in case when you're prescribing drugs for hepatitis C. Oh no, not again. Okay, this is essentially just a first aid table, a comprehensive table about the viral hepatitis C drugs. Let's move on to questions. So, which class of hepatitis C drugs inhibits viral protein assembly and replication complex formation? So that's going to be NS5A. So NS5A, again, it's replication complex inhibitor because it prevents the protein assembly and formation of replication complex. All right. Which patient with decompensated liver cirrhosis should not receive which antiviral? If you remember, I said that they cannot receive interferon alpha. Because interferon, I'm guessing that it overcompensates, it overwhelms the immune system. So this can worsen the cirrhotic complications of the patient. Which antiviral drug is most associated with nephrotoxicity? That's going to be adifovir. Yes. Patient with chronic hepatitis B started on drug, high potency, low resistance, safe in pregnancy. What is that? Tinof. That I believe is tenofovir, tenofovir, hepatomegaly. So this has to be C. Just gonna change it right now. Now, we're moving on to the last lecture. I hope you guys are doing well. Just one more push and we'll be done, inshallah. Okay, so for liver cirrhosis, liver cirrhosis is a very chronic condition that happens because of several underlying factors. It could be chronic alcoholism, it can be fatty liver disease, which is non-alcoholic steatosis. Yeah, it could be viral infections that lead to chronic infections, which lead to cirrhosis. Yeah, so for us, when we think about treating cirrhosis, we think about obviously treating the underlying cause that prevents cirrhosis. We think about treating the cirrhosis itself, so reversing the fibrosis. Cirrhosis is essentially fibrosis, and also treating the complications of cirrhosis. Okay, let's move on. So preventing cirrhosis, obviously, you want to treat the underlying cause, and you want to treat the cirrhosis, prevent the underlying, oh my God, treat the underlying cause to prevent cirrhosis. Treat cirrhosis by using antifibrotic agents, and also cirrhotic complications such as portal hypertension, esophageal varices, ascites, spontaneous bacterial peritonitis, and also hepatic encephalopathy. Okay, so first we'll try treating the underlying cause. What could be the underlying causes? This is directly from the slides. So autoimmune hepatitis, obviously, if something is autoimmune, you want to give them something that is anti-immune or anti-inflammatory, such as prednisones, or steroids, and immunosuppressive drugs such as azathioprine. Hepatitis B and C, we took a whole lecture on it. The hepatitis vaccine, antiviral agents. So for hepatitis B, we took lamivudine, tenofovir, adofovir, and entecavir, and also interferons. For hepatitis C, interferons, ribavirin, and the direct-acting agents. Then for metabolic dysfunction-associated steatotic liver disease, or NAFLD, and NASH, or MASH, whatever it's called now, the names keep changing, you need to do lifestyle modifications first because it's caused by obesity. So you need to do weight loss, sugar control, glycemic index control. Alcohol-related liver disease, obviously, you cause alcohol cessation or avoid alcohol. Hemochromatosis, you do phlebotomy. Hemochromatosis is when you have excess of iron in the liver, and so you can use iron chelation therapy and phlebotomy. Primary biliary cholangitis, for this you can use ursodeoxycholic acid, which I believe decreases the bile formation or conjugation, I forgot which one. And Wilson disease, which is an excess of copper, so you'll use penicillamine or copper chelators. Okay. So let's say we couldn't prevent cirrhosis. Now we already have cirrhosis. How do we prevent it? There is only one FDA-approved drug so far, which is called resmetirom, that is approved for the use of cirrhosis. Now, what is it used for? It's used for moderate to severe cirrhosis, and it is the only known drug to essentially reverse the effects of cirrhosis. What does it do? It enhances hepatic fat metabolism and reduces the inflammation. Which makes sense. It makes sense that we cannot use interferons in hepatic inflammation or cirrhosis because it will worsen the cirrhosis. Instead, we use something that is anti-fibrotic or anti-inflammatory to decrease the metabolism of fat and to reduce the liver inflammation. So what is the mechanism of action? It is a selective thyroid hormone receptor beta agonist. Okay, so it's selective thyroid hormone receptor beta agonist. It's just pure memorization. Is there a way I can remember? I guess THR is similar to the TIR here, but other than that, not really. Okay, so now let's say you could not treat the cirrhosis and you have complications. How do you deal with the complications? First, the most common complication is portal hypertension. What is portal hypertension? As with any other hypertension, increase in the pressure of the portal venous system. So hepatic venous pressure gradient of more than 5 millimeter mercury is known as portal hypertension, and clinical complications occur when the pressure is more than 12. So why does it happen? It happens because of hepatic resistance. So when you have a cirrhotic liver, it's basically a hardened liver, and blood cannot really pass through it. There's a lot of intrahepatic resistance. And because of the structural functional changes of the liver and also splanchnic vasodilation, you will have increased hepatic resistance, which causes portal hypertension. Okay, so portal hypertension can cause variceal bleeding because of the splanchnic vasodilation. So for these, you can use non-selective beta blockers. One way to remember what is non-selective and selective is that anything from A to M is selective, and anything from N onwards is non-selective. But there are a few exceptions. Okay, so N onwards is non-selective, and anything from A to M is selective. However, please look into it to see the exceptions, basically. So, anyone with variceal bleeding as a result of portal hypertension, you need to first resuscitate and stabilize. Always remember ABCs for variceal bleeding. This is not as important for you guys. Obviously, pharmacology aspect, we focus more on the drugs. But when you go to 4th and 5th year, in the OSCE especially, you'll have to remember to resuscitate, stabilize the patient. So it's a good habit to see, whenever you see bleeding, immediately stabilize the patient because you never know how much the bleeding is, right? So you always need to check for hemoglobin, check for blood pressure, see if there's a massive bleeding. Now, to prevent the bleeding, as we said, we use non-selective beta blockers. However, if there is bleeding, we use something called octreotide, which is a somatostatin analog, and it inhibits the secretion of vasodilator hormones. So, because of this flank-link vasodilation, we have the bleeding, right? So if we inhibit the vasodilation, in other words, if we cause vasoconstriction, we will reduce this flank-link blood flow and decrease the portal hypertension, and also decrease the bleeding. So octreotide is the first drug of choice in cases of acute variceal bleeding because of portal hypertension. There are other drugs such as terlipressin, which is a vasopressin analog, and we can also do antibiotic prophylaxis and electrolyte and vitamin repletion. We can do antibiotic prophylaxis because one of the complications of cirrhosis is spontaneous bacterial peritonitis. So antibiotic prophylaxis is going to help with that. And okay, and because of this because of liver failure, liver slowly going into failure, we can have decrease in some of the synthetic functions of the liver, such as albumin or vitamin K. So we can replenish those in the patients as well. Secondly, ascites. So, how do we treat ascites? More importantly, what causes ascites? If we know that, we know how to treat ascites. So, ascites is essentially a huge collection of fluid in the abdomen, and it is very commonly seen in cirrhotic patients. It's a common complication. Now, why does it happen? It happens because of failure to synthesize albumin, among other factors. Now, if we have decrease in albumin, which is produced by the liver, now the liver cannot afford to produce so much albumin anymore. What will happen? We will have decrease in the albumin in the plasma and decrease in oncotic pressure of the blood vessels. If you have decrease in oncotic pressure of blood vessels, water will extravasate from the vessels and go into the nearby tissues, and this will cause collection of fluid. For ascites, we use, obviously, since it's a collection of fluid, we want to drain the fluid, right? So we do paracentesis, which is to diagnose and to treat. So it's both diagnostic and therapeutic. And we also give the patient diuretics. Now, what kind of diuretics do we use? We use aldosterone antagonists or potassium-sparing diuretics, and in addition to furosemide. Now, you can see that loop diuretics are used and potassium-sparing diuretics are used as well. And this is because furosemide is a loop diuretic, but it causes hypokalemia. So to prevent the complications of hypokalemia, we use something that is potassium-sparing as well. So spironolactone and furosemide. Okay, and you need to avoid NSAIDs and ACE inhibitors as well. All right. Another complication, as I mentioned, is spontaneous bacterial peritonitis, which can happen because of this collection of fluid. Anywhere where you have a collection of fluid, whether it's pus or ascites or anywhere where you have collection of anything that causes stasis, is a breeding ground for bacteria. So when we have ascites, we have stasis of fluid, right? So this stasis of fluid is going to accumulate bacteria, most commonly gram-negative rods, such as E. coli and Klebsiella, and this will cause increase in the neutrophil count. So more than 250 is diagnostic for spontaneous bacterial peritonitis. Treatment is usually with third-generation cephalosporin to have the gram-negative coverage as well, and it's given IV because if left untreated, it is actually very dangerous. And if you suspect multi-drug resistance, you give them piperacillin tazobactam or meropenem, which are carbapenems. Okay, so how do you remember this? Or not really how do we remember, but what do we exactly remember? So remember prevent, treat, and treat again, persistence, when it's a persistent infection. So how do you prevent? With ciprofloxacin. How do we treat? With IV third-generation cephalosporins. And how do we treat in case of resistance? We treat with piperacillin tazobactam or meropenem. And we also give them IV albumin because the the peritonitis usually happens because of ascites, as a result of ascites. And when we have ascites, when do we have ascites? When we have decrease in albumin. So we want to give them IV albumin as well. This is a very ugly slide. I'm sorry about that. Another very, very dangerous condition or complication of liver cirrhosis is hepatic encephalopathy. Now, when does this happen? This happens when you have cirrhosis. And because of cirrhosis, some of the metabolites that are supposed to be metabolized by the liver are not being able to be metabolized. And one of these is ammonia. So what does ammonia do since it's almost gas? It goes to the brain and it causes altered mental status. So what do they have? They have flapping tremors, they have asterexis or flapping tremors, the same thing, and also altered mental status. Okay, so because all of this is because the liver cannot metabolize the ammonia. So our main goal of treatment is to reduce the ammonia levels, obviously. How can we do that? This is where our friend lactulose that we met earlier is coming into play again. So lactulose is an osmotic laxative, and as I mentioned, osmotic laxatives bring water into the bowel. Right? So that is one of the reasons why it's a laxative and why it is used here as well. So if you have a laxative, you'll have increase in GI motility. So everything is happening fast, right? So you'll have diarrhea. And so if you have everything happening fast, you'll have decrease in absorption or decrease in the amount of time that you're giving ammonia or ammonium to be absorbed into the GIT or absorbed into the GIT. So if you give them less time to be absorbed, you'll have more ammonia that is excreted. Another mechanism that is involved here is, remember I told you lactulose is broken down into lactic acid and acetic acid through the enzyme called galactosidase by the bacteria in the colon. This causes acidification of bacteria. Now remember chemistry. So when you have an acid and you have an alkali, they react together and they neutralize. So ammonia is an alkali and it causes ammonia to ammonium formation. How do I remember this? Acids are essentially excess protons, right? So excess hydrogen ions. So when you have excess of acid, such as lactic acid, you will have conversion of ammonia to an excess of proton, which is NH4 plus or ammonium ions. And this decreases the absorption of ammonia by the colon. So there are two mechanisms that lactulose has in order to There are two mechanisms that lactulose has in order to decrease the ammonium levels. One is acidification of the gut to decrease the formation of ammonia and increase the formation of ammonium, which is less absorbed. And another one is to increase the GI transit time. So the GI keeps moving, there is no time to absorb all the ammonia. Okay, another antibiotic essentially that is used here is rifaximin, which is a broad spectrum antibiotic, and it's non-absorbable. So if you use non-absorbable antibiotics, they decrease the ammonia absorption. So you can use rifaximin, neomycin, vancomycin, or metronidazole. What are the indications? If you have no improvement in 48 hours and to prevent recurrence. So first line always is to use lactulose. If that doesn't work, we will move on to rifaximin. If no improvement in 48 hours. I believe that's the end of teaching. Let's do a few questions. So, 58-year-old man with the history of liver cirrhosis secondary to chronic hepatitis C brought to the emergency department by his family due to progressive confusion and disorientation over the past 2 days. He has been increasingly lethargic and has had difficulty with basic tasks. On examination, he is disoriented to time and place, with asterexis noted on neurological exam. Liver function tests are consistent with his known cirrhosis. Diagnosis of hepatic encephalopathy is made. The patient is started on appropriate therapy. What is the aim of treatment? So the answer is going to be lowering serum ammonia levels. What is the drug that we use? We use lactulose. Here, even if they didn't give you that hepatic encephalopathy is the diagnosis, you can say that it is the diagnosis because the patient has asterexis, which is flapping tremors, and also asterexis, which is flapping tremors, and also hepatic encephalopathy, altered mental status. So he's disoriented to time and place. So this tells you that it is hepatic encephalopathy. He has a long-standing history of liver cirrhosis. Okay, patient with ascites treated with spironolactone, furosemide. What is the purpose of combining these two drugs? It is to prevent hypokalemia, as I mentioned. Furosemide, loop diuretic, causes hypokalemia. Spironolactone, potassium sparing, does not cause hypokalemia. Okay. Patient with portal hypertension started on beta blocker that reduces the portal pressure by decreasing output and splankling blood flow. Oh, okay. I believe the answer is given in the question, actually. Which receptor blockade is responsible? It is going to be, the answer is given here as well. Oh, that's crazy. It's going to be beta 2. So in liver cirrhosis, there is chronic splanchnic vasodilation because of the cirrhosis. So for example, this is a blood vessel, let's say, okay? And you have cirrhosis from both sides. So cirrhosis from both sides pulling in the blood vessel. So that causes vasodilation. So if we give a drug that is a beta blocker and it causes vasoconstriction, you will have decrease in the amount of blood flow and decrease in portal hypertension and variceal bleeding. Okay, I'm sorry the answer is given here as well. Can cover it. Um, a patient with cirrhosis develops spontaneous bacterial peritonitis. What is commonly used for prophylaxis to prevent recurrence? It is going to be, oh, sorry, norfloxacin, or ciprofloxacin, basically, which is used for prevention. Okay. All right, that brings me to the end of the session. I'm sorry if there are any mistakes. If there's anything, please feel free to let me know, and so that I can let the batch know as well. And thank you so much for listening to this. It's a recording, so thank you so much for listening. I hope it helps you in your preparation. If you have any questions at any time, I know GIT, it's a very interesting blog, but it's also very stressful to study for because there's a lot of clinical lectures, a lot of pharma, a lot of pathology as well. And it's just a lot going on all over the place. So, but remember that if you know the high yield stuff, you can answer at least 70 to 80% of the questions. Don't sweat it too much. GIT exams are notoriously known to be a bit difficult, but all you can do is try your best, okay? If the exam is difficult, remember that it's difficult for everyone, so don't really worry about that aspect. Don't worry about what's not in your control, just worry about what is in your control, which is your best to do, study your best, inshallah, Allah will take care of the rest. That's all I'm going to say. Thank you so much for listening. If you have any feedback or comments for me, if there's any way you want me to improve the sessions that I give, scan this QR code, let me know. If you like my sessions, also let me know. Thank you very much.